Hello everyone, good evening. So today, as discussed, we will be discussing the rest of the cases of autumn 2015 session, starting from case number 11. Okay, so without wasting much time, we're just going to the case number 11. The history was given at male 60 years and a colonoscopy investigation was done for diarrhea and 12 polypodal mucosal lesion was detected on colonoscopy. So if we go to the microscopic image of the polyp, we see that this is a polyp which shows actually there are crypts are bit of abnormal orientations. So we know that these crypts are star shaped with this is known as serrations, and if we go in this field where we have the crypt better oriented, we see that crypts are going down up to the muscularis mucosae and it is spreading over the muscularis mucosae in a inverted T or inverted L shaped pattern, also known as boot shaped crypts. Okay, and the serration is identified along the length of the crypts. Okay, so this is a serrated lesion, and if we go down to the degree of dysplasia, we see very low kind of dysplasia in this lesion. Okay, so we know that this is a serrated lesion, known as sessile serrated lesion, and this is actually in a spectrum of serrated lesions. Okay, and it is more common towards the right side of the colon, and there are some terminology known as sessile-serrated polyposis. When you have more than 5 polyp, at least 2 of them is more than 1 centimeter, kind of that. So this is known as sessile-serrated polyposis. You can see some uh, genetic alteration, predominantly BRAF mutation in this kind of polyp, and the carcinoma that develops from this is known as associated carcinoma, and that molecular pathway is given in elaborated way in WHO GI fascicles. So you can refer to the chart, and you say that it is a associated lesion, and once excised, this doesn't actually harbor any mutation or any chance of carcinoma, and the colonoscopic finding to be discussed in a MDT. And you can suggest that okay, the BRAF mutation status can be done on this particular biopsy to denote the underlying molecular alterations. Okay, so nothing much in this particular case. So this is how you complete the answer and move on to your next case. Okay. So our next case is case number 12, that is given a 56-year female patient with large calculus in the right renal pelvis, atrophic right kidney. This simple nephrectomy was done. So what we have, this is a section from the simple nephrectomy specimen. We can see the perinephric fat over here, the renal parenchyma is uh, is infiltrated by this kind of nodular lymphoid aggregate, and with formation of the germinal centers. The tubules, interstitium is quite inflamed. The tubules are showing features of atrophy. The interstitium showing features of fibrosis over here. The vasculature showing medial hypertrophy, which is a feature of hypertension in this patient. So this is quite a bunch of vessels with medial hypertrophy. These are the germinal centers, and there is a area which have this kind of pathological features with cholesterol cleft, lots of lymphoplasmacytic cells, foam cells. Okay, and few of the foam cells have the pigment also. These are the brown pigment, which is actually a telltale sign of hemorrhage in the lesion. So, and few of them have the multiple nuclei. So this is a giant cell. Okay, so this is a case of xanthogranulomatous pyelonephritis. Okay, so xanthogranulomatous pyelonephritis can be due to some risk factor. The patient may be diabetic, or patient maybe have some inherent like urological manifestation, like there is a recurrent UTI, and there is a vesicoureteral reflux, which is causing recurrent pyelonephritis and ultimately giving rise to this kind of xanthogranulomatous pyelonephritis. One important differential you should keep in mind: this kind of feature can also be seen, uh, although the foam cells will be much less in number uh, in case of malakoplakia. So malakoplakia can be seen in kidney, and that can make a sinus to the overlying skin, producing a pyocutaneous uh, sinus. And in that case, you need to find that Michaelis-Guttman body and the characteristic histiocytes with lots of eosinophilic cytoplasm rather than this kind of foamy cytoplasm. So you can say this is a these are the risk factor, and this is a kind of end stage renal disease. So the kidney has been sacrificed, and there is no kind of granuloma or atypia in the surrounding kidney, and patient should be followed up because there is already evidence of hypertension in this. So this is a medial hyalinosis. So the well-established feature of hypertension going on. So patient can be followed up in nephrology OPD, and CPC can be done for this case. Okay, now moving on to our case number 13, that is a female 51-year female with a retroperitoneal mass, which is quite huge, 280 millimeter retroperitoneal mass, which is resected. So from the scanner view or from the lower magnification, we can see that it is a kind of adipocytic lesion, which having kind of septa, which is dividing the adipocytes into lobules. And if we go down to the fat, we can see the variable sizes of fat. Actually, few are small, few are large. And uh, if we go around, and if we actually concentrate on the septa, we see the septal mesenchymal cells or spindle cells are quite atypical. Look, this is the quite atypical cells, and few of them have bizarre nuclei. So this is another evidence that it is a kind of atypical. So this is also a lipoblast. Okay, even though a lipoblast can is not mandatory for diagnosis of well differentiated liposarcoma or atypical lipomatous tumor, it is better if you find it, if you mention it, that is better. And one characteristic feature, this kind of variable sized fat adipocytes. Okay, and look at the atypia of the septa, which is quite significant. So this is a diagnostic for well differentiated liposarcoma. You should give a FNCC grading, and you say that in further workup you will do obviously look for MDM2 and CDK4 IHC. So you expect that to be positive, okay? And you should also say that I will take other section to look out at the complete resections and the margin status, all that. And you say that this have some molecular alteration of chromosome 12, and that helps. And this is a part of bony metaplasia. bony metaplasia that is happening within the lesion. Okay, and obviously you should take section to exclude a dedifferentiated liposarcoma, which is quite common in retroperitoneum. Okay. And the case to be referred to sarcoma referral center, where the further management guideline to be given, and depending on the margin status, they can follow up with the radiotherapy per se. Okay, so this is how you complete the station, and this is a good example of well differentiated liposarcoma, and you should look for a dedifferentiated area per se. Okay. Now moving on to our case number 14. Male 40 years and a given history was a intravenous drug abuse, and the patient presented with enlarged right inguinal lymph node. The lymph node biopsy, excision biopsy has been done. So from the magnification, lower magnification, we can see that this is kind of very pink node, and very less amount of bluish or lymphoid area uh, is there. So if we go down to the lymph node on higher magnification, we can see this kind of sheets of epithelioid cells and their kind of macrophages with a voluminous amount of cytoplasm. Okay, and just going back to a bit lower magnification, here we can see the lymphoid follicle have been eaten up by this kind of granuloma, which is eating up, and in it is infiltrating into the germinal centers. Okay, and this is the medullary part of the lymph node, and this is the another half of the lymph node where also we can see this kind of granulomatous inflammation and predominance of macrophages. Okay, so and we need to exclude that there is no atypia in the histiocytic element, and they are more or less very benign or banal kind of histiocytes, and there is no atypia or mitosis seen. And if you go down and see that these histiocytes are filled with eosinophilic or granular cytoplasm. So that is a clue to some kind of uh, intercellular pathogen with a history of intravenous drug abuse. So in a young male, 40 years with intravenous drug abuse history, you should keep a mind of any immunodeficiency and associated infection. So you should say that it is a granulomatous lymphadenitis, and I suspect that some kind of tubercular or atypical tubercular infections. It may be some sexually transmitted disease like chlamydia and all that. So these are the differential, and you will work towards it. And you will in a workup section, you write that I will do a ZN stain section, ZN stain specifically to see the mycobacterial etiology per se, and you can correlate with the PCR. You can send the tissue to microbiology lab for tubercular PCR, for chlamydia, Yersinia. These are the opportunistic infection that can happen. And you should also do a CD4 count because you want to know about the immune status of the patient. You must do a clinicopathological correlation that whether the patient have some immunosuppressed state, patient is known of some kind of positive, like patient is HIV positive or under some medication like heart therapy. So this kind of workup is needed. This can be referred to a tropical center once this is proven to be a tubercular origin, and appropriate therapy will be started. Okay, So this is how, and you must put a differential of atypical tuberculosis, because in immunosuppressed patient, the atypical tuberculosis comes first, because the typical tuberculosis will have some kind of necrosis within it, and the cells are more epithelial rather than this kind of foamy appearance of the macrophages, which is more seen in the Whipple's kind of thing in GI, if you remember. So this is how you work up this case. You have a discussion with the clinician, and you write down whatever you feel in the microbiology correlation and all that. So this will help to pass the section. Okay. Okay. Now moving on to case number 15, that male 38-year abdominal pain and CT scan was done. A small bowel stricture was detected, and the section was given from the small bowel stricture. So, from lower magnification and with the history that the patient is kind of young patient and a small bowel is involved. So this is definitely a stricturous part. It is giving a appearance of kind of a luminal esophagus or with kind of stellate lumen. If we go down to higher magnification, we see that this is ulcerated, and this area which is going into the deeper part actually are fissures. So these are the ulcerated mucosa with fissure. Okay. And if you go in certain part of the section, you will see this kind of non-caseating back-to-back epithelioid granulomas in the sublamina propria. And if you go along the wall of the uh, ileum or small intestine, you will see that lymphoid aggregate is seen in many parts, also reaching up to the serosa. Okay, so serosa muscularis and all that have lymphoid follicles. So with the history that the patient is having a small bowel stricture, lymphoid follicles, increased fibrosis, increased actually non-caseating granuloma, and fissure ulcers are pointing towards a history, towards the diagnosis of Crohn's disease, inflammatory bowel disease. That is a Crohn's disease, likely or definitive for Crohn's disease. Okay. So now how will you work up this case? So you will correlate with the previous biopsy if there is there, like mostly the patient will have either other systemic like GI involvement, like patient will have either gastric or esophageal, or the ileal area will be involved. So upper GI endoscopy or the colonoscopic biopsy you should look for in your LIS, and you just go through the treatment history, whether the patient has been given treatment for Crohn's disease per se, because and you say that there are no actually a very good marker, serum marker for Crohn's disease, but you can do a stool calprotectin, because calprotectin is elevated in inflammatory or infective origin, sorry, infective origin, rather than in case of Crohn's disease or autoimmune diseases. So it kind of raised calprotectin will exclude the possibility of infective or chronic infective etiology per se. Okay, and Crohn's disease can be detected on previous upper GI endoscopy or colonoscopic biopsy. So that kind of correlation will be discussed in clinical pathological correlation. And you say that even though this part is resected, the patient should be under strict follow-up, because this can this can have a recurrence or multiple episodes of abdominal pain, and patient is not actually disease free. The patient can have a recurrence, or it may have some flare up. So this kind of information will show that you are aware of the natural course of the disease. Okay, and sometimes Crohn's disease are associated with some other multi-system diseases. So you write down that to increase your marks and gain some other brownie points. Okay, and yes, you can suggest some other special stains like Zn stain and PAS. Actually, if you are not sure, just for completion sake, it is not like that you are considering a inflammatory or infective pathology per se based on these granulomas. Okay, so you just want to exclude a superadded tubercular or some kind of fungal infection that can happen. Just you need to be very sure that you are a safe pathologist. Okay, so pasting can be done in these sections. Okay. Okay, now moving on to our case 16, that is male 83-year. So this is a pleural effusion. There is a history of pleural effusion, and a clinician have done uh, that is your video assisted thoracoscopic surgery, and a pleural biopsy was obtained. So this is a multiple fragment of pleural biopsy, and if we go down into the higher magnification, we can see there are some cellular area and other areas are kind of necrotic. And if we concentrate on the cellular area, it is very pleomorphic. Okay, so this kind of diffuse sheets of highly pleomorphic cells, predominantly spindle to oval, some epithelioid cells, some area. This is a outright coagulative necrosis, and there is atypical mitotic figure going on. So this is definitely a malignant lesion. That is, there is no doubt. There's plenty of mitosis going on. So in case of a aged male with pleural effusion and a pleural biopsy showing this a sarcomatoid and epithelioid feature, you should say that it is a malignant pleural biopsy, and I favor a sarcomatoid mesothelioma per se, and I will exclude the other possibility, that is carcinomatous, sarcomatous carcinoma or any poorly differentiated lymphoma. Okay, so that kind of broad differential you can put, but you should consider the possibility of sarcomatous carcinoma. Sarcomatous mesothelioma. So sarcomatous mesothelioma is rare. It is almost 10 to 15% of all mesothelioma spectrum, that is epithelioid, biphasic, and sarcomatoid. So it is only 10 to 15%. But the thing is that sarcomatous mesothelioma have a poorer outcome. Okay, and you suggest that I will do some broad marker, especially the pancytokeratin, CK56, calretinine, okay, CD30 as well as CD45 to exclude any possibility of lymphoma in this case. And you say that sarcomatous mesothelioma is a referable case. You need to refer this case to the center with, it is an occupational disease, so the patient occupational history as well as a compensation is related to this case. So and the patient can be managed with pleural decortication. So advanced center where there is a facility for cardiothoracic surgery is there. The patient can be referred there. And you say that ISC marker I will do to confirm that that is your CK56 I expect positive, calcitonin I expect positive, and also the BAP1 negative as well as MTAP negativity. And if you do a fish, there is a biallelic deletion of P16. These are the marker for mesothelioma. And you say that I will also revisit the cytology, what it has been given particularly for this case. So this kind of correlation will show that you are aware of how the pleural effusion and all that are worked up. Okay, so this is in nutshell how will you approach this case. Okay, and say that this is a prognostically very poor, the prognostic out, sorry, the life expectancy is in few months to only few years. Okay. So this is how you work up and complete this case. Okay. Okay, now moving on to case number 17. Case number 17 is a elderly male, 79-year male, and the patient is having a history of dysphagia. So esophageal biopsy was done. So there are multiple fragments of esophageal biopsy, and if you see that all these biopsy are lined by columnar cells. Okay, so even though it is a esophageal, there is no actually any squamous lining per se, and in few of the beads there you can see this kind of clear cell which are actually giving a impression of goblet cells. Okay, so intestinal metaplasia is there, and in few of the beads you can say there is cellular crowding, there is stratification, there is mitosis. The nuclei are pencillate, even though it is not reaching up to the upper half of the cell thickness. Okay, so there is definite cellular crowding, there is increased mitosis, there is hyperchromasia, there is loss of cellular mucin. So all these are pointing towards dysplastic process. So the columnar line esophagus or CLO is also termed clinically as Barrett esophagus. So you can say that I suspect, again, this is another area of intestinal metaplasia. So these are the adjacent intestinal cells. So I suggest that this is a which this biopsy suggests a possibility of Barrett esophagus with low-grade dysplasia. So how will you work up this case? You will definitely correlate with the endoscopic biopsy that there is salmon color mucosa above the gastroesophageal junctions, because you know the gastroesophageal up to the gastroesophageal junction it is pale mucosa because of the squamous lining. So once it is replaced by columnar epithelium, it becomes a salmon color or reddish mucosa. It can be it can be of variable length, and depending on the length they divide into short, ultra short or long segment Barrett's. And there is a screening protocol for dysplasia. So the patient will be through that pathway of screening for any dysplasia, and the patient is already in uh, low grade dysplasia. So the further follow up can be done with endoscopic mucosal resection, EMR. Okay, and you say that I will confirm the dysplasia by means of certain markers, even though it is morphologically suggestive of, because there is no inflammation per se, it is not looking reactive. So the first thing I will do, I will have a colleague opinion, number one. Then this is one kind of case where dysplasia need to be confirmed with another pathologist, and the Barrett is one of them. Please remember this, and they will test you whether you know this particularly. Okay, so you first confirm with another pathologist, colleague pathologist in your department. You can do another marker like P53. So the P53 will show increased staining or mutated staining pattern, and the Ki67 index will be increased. So these are the supportive and markers for Barrett esophagus with dysplasia. Okay, so next you can say that I will discuss this case in the GIMDT, and the next possible that is management step will be EMR, and the EMR will examine the completion of the resection and all that. So that is the next step actually. Okay, so this is how you complete this step, and you say that this dysplasia is related with the age, the duration of Barrett's, a GRD, and there is it can progress to adenocarcinoma unless it is treated. So this kind of message you can give in a additional information sections. Okay, so this is how you deal this case. Okay, now moving on to case number 18. 18 is a male 28-year male patient having a right middle finger lesions. Okay, so if you evaluate the section under microscope, you see that there are few fragments of this biopsy. Okay, and one of them is lined by this squamous epithelial cells with this kind of uh, tires of keratin, which is suggestive that this is taken from the digit or from the acral side, and there is area of hemorrhage here. So this can be due to some trauma, and there is some histiocytic aggregate over here. This biopsy is not very much useful rather than only acanthosis there. And if you go to the other beats, you see that this is a cyst-like area which is lined at the outset with dense fibrous capsule-like structures. And if you go inside that cyst-like area, you see that there are some kind this papillary which is having a dense fibrous or hyalinized core, and the papillae is lined by very flattened cells, and interpapillary area you can see this erythrocytes or RBCs. Okay, so this is one area, and also in other areas they're kind of compressed or very kind of back-to-back vascular channels, but the papillae they are densely fibrous or hyalinized, and the lining is flattened. There is no overlapping per se. Okay, these are the areas where you can see some histiocytes as well as endothelial plump endothelial cells. Okay, so again this is a channel which is on the process of revascularizations. There is a evidence of old hemorrhage or thrombus over here. So you can see fibrin, inflammatory cells. So yeah, it is a area of thrombus which is being recanalized, and again we can see this kind of papillary area. So this is a benign lesion. There is no infiltrative lesion. It is not going beyond this peripheral fibrous pseudo encapsulation, or you can say the altered vessels which has been actually thrombosed and now on the process of recanalizations. So this is a papillary intravascular endothelial hyperplasia, also known as Mason tumor. Okay, so Mason tumor is a benign lesion. Uh, some uh, some it was detected mostly at the site of trauma and in a process of recanalizing the thrombus blood vessels. Okay, so this is the etiology is mainly trauma induced thrombus. Okay, and you can say that the I don't consider angiosarcoma per se, and you can say that this will be the CK negative and the vascular marker will be positive. CD31 and D240, this kind of marker will be positive. CD31 and 34, D220 will be uh, negative. Okay, so this is how you can say that even though the IC is not required, these are the markers that can come positive. Okay. So this is Mason tumor, or also known as papillary intravascular endothelial hyperplasia. Okay. Now moving on to case number 19. This is a comparatively straightforward case. A male of 75 years with a only short history of blistering disease in the lower leg or anterior chest. Okay. So the incision biopsy was done. So now what we have this subepithelial blisters. Okay, so the epithelium has been lifted off. There is a papillary dermis, and the vesicle is filled up with inflammatory cells and lot of eosinophils also. Okay, so inflammatory infiltrate is there, perivascular lymphocyte aggregate, along with uh, there is also eosinophil. It is a subepithelial vesicobulous lesion. Okay, so there is no acanthosis, no sorry, acantholysis, particularly for this case, and the blister is of significant size. The adnexal size all okay. The deep dermis is all okay. Subcutis is not included. Okay, so with the history that it is a old age and subepithelial vesicobulous lesion, the first differential should be bullous pemphigoid. So bullous pemphigoid, you can do certain markers, that is a BPAG1 and BPAG2. So they are the serum markers that comes positive. Okay, and you say that this bullous pemphigoid is typically seen in the old age, in the lower extremity, and it is a tense bulla because the fluid collect under the epidermis, and it is a kind of self-limiting disease. So, and IF is also needed for proper diagnosis. Okay, now moving on to our last case, that is a male 56-year with abnormal chest X-ray and wedge resection was done. So this is an interesting case because we can see from the lower magnification a significant area of necrosis. So this is an area of necrosis, this kind of eosinophilic necrosis. If we go towards the periphery of that area, we see that this necrotic area is palisaded by these histiocytes. Okay, they are kind of palisading histiocytes, and there are few necrotic debris. These are the karyorectic debris that is seen at the um, periphery of the necrotic lesions. Okay, and there is one vessel. This is one vessel which is having a dense inflammation, so vasculitis is there. Okay, so this is vasculitis going on at the side of necrotic area, and there are few scattered areas which is having this kind of granulomatous lesion which is having yet to be undergo necrosis. Okay, and the periphery of that area is inflamed. There is lymphohistiocytic inflammations. There is also lymphoid aggregate in the centriacinal zone. But overall, there is nothing to be worried about on the pleural side. The pleura is all okay. The vessels is fine. There is no medial hyperplasia per se. Okay. So this is how you describe that. This is a granulomatous lesion, granulomatous inflammation. What are the differential in this case you can think of? You can think of quite a number of differential. One is obviously tuberculosis, because you see that palisaded granuloma and epithelioid cells, okay, with this kind of necrosis. But the thing is that when you see this vasculitis, so there should be some concern about rheumatoid also, rheumatoid arthritis. So definitely you should do some serological evaluation for, because these are again a fibrin-rich granulome, fibrin-rich area, and there is a vasculitis. So you should suggest that rheumatoid nodule is another possibility. So how will you approach this case? You will do some stains, predominant, firstly the Zeal-Lenzer stain, the PAS stain, as well as the silver stain, to just exclude the possibility of any infective etiology. Once that is ruled out, then you can think of or discuss with the clinician that whether the patient is already have some history of rheumatoid arthritis, either the patient is under the treatment, because once rheumatoid arthritis patient detected to be having a lung nodule, usually the disease flares up. Okay, this actually precedes with the disease flare. Okay, so you should do anti-RA as well as anti-CCP to actually confirm the possibility or exclude the possibility of rheumatoid arthritis. And you say that rheumatoid arthritis can be detected with some radiological features also. So radiology and psychopathological correlation to be done in clinical setting, clinical meeting. Okay, so this is how you approach this case. You should not give a differential of malignant lymphoma. You know that lymphomatous granulomatosis can have a wide area of necrosis, but you should have large visceral lymphoid cells to detect or to suspect about the lymphomatous granulomatosis. So in a benign case, you should not give a differential of malignant neoplasm or malignant lymphoma. Okay, so this is how you approach this case, and actually rational what you are thinking of. And also it is the in this kind of case, it is very important to discuss with the clinicians and keep a possibility of rheumatoid arthritis. Okay, so this is how we complete this rest of the case of autumn 15. And if there is any doubt, please put that in your chat. Okay, so there is a query regarding the Barrett. So in Barrett, you need to, the best treatment you can offer is EMR. It is endoscopic mucosal resection in case of low-grade dysplasia. So if the patient opt out of EMR, then the endoscopic surveillance can be done. And you need to go through the college document for endoscopic surveillance. Okay. Dr. Subhashakti, are all tuberculosis cases referred to tropical centers? Can we write that in remarks? Yes, you can say that these are the tropical diseases, and these cases can be referred to tropical centers if the patient wants. It is not actually a very universal kind of practice in NHS, but the tropical disease like tuberculosis, like some Kala-Azar, Hydatid, all that, they're mostly acquired, mostly prevalent in the tropical country. They can be referred to tropical centers. Okay, another question is that case number 16, can we put a melanoma in the diagnosis? Okay, so what was the case number 16? Okay, pleural biopsy. Yeah, you can put a differential of melanoma without a pigmentation, but the thing is that you must consider a sarcomatous mesothelioma. Otherwise, if you don't put, you will gonna miss the session You may be having a borderline fail mark. So obviously, as we have considered, it can be lymphoma also, it can be sarcomatoid carcinoma also. So this kind of differential is accepted, and this is a particularly differential case which you need to be kind of very broad minded, and you put a very IHC table, you put a marker, the linear specific marker. So yes, melanoma is accepted for this particular case. Yes. Is it necessary to, yeah, yeah. Dr. Sujata, it is necessary exactly. So there, yeah. So the question is that, is it necessary to go for a second opinion to confirm a low-grade dysplasia is Barrett? Yes, it is. It is actually a necessary thing. You need to say that Barrett and one another dysplasia. I am forgetting. Um, I'll just come back with the answer. So Barrett is one of the session when you must have a second opinion for confirming dysplasia along with some ISC markers. Yeah, Barrett with dysplasia is actually, yeah. Can we have a differential of polyangiitis with granulomatosis in the last case? So Dr. Akhtar, I think uh, you are considering the lung case, I suppose. So yes, so you can put a differential, but the thing is that you must show that there is eosinophils more in number, okay, and there are more kind of vasculitis apart from this one or two vasculitis. So yes, you can put a differential of eosinophilic granulomatous with polyangiitis, that is accepted, but we should also consider the possibility of tuberculosis as well as rheumatoid nodule that are more common. Okay. So, yes. Yeah, Dr. Sujata, I've asked you, where do you refer to the occupational diseases? There is a occupational disease in NHS. It is a referral system actually. Uh, there is nothing such I like it is to be referred. There are few centers in the NHS which runs as a occupational disease center. So there are multiple centers, and they are actually the mesothelioma and all others, that is occupationally acquired diseases, they are referred. There are multiple centers actually. Okay. It is a referral center. If you write down that it is a occupational disease referral center, that suffice. Case 17, low-grade dysplasia observation. Oh, that question has also already been discussed. Okay, so I think there is all the question that is there, we have answered it. Um, so if you like our this effort, please subscribe, and we'll continue this venture until all the leads exam are over. So we'll continue every week. That is on the Saturday and 7:30 p.m. The notification will be given to the groups, and the link will be there. So please like and subscribe to our channel so that you can get any interim videos also. We also put on any adding on the videos which are relevant to the short surgical or some important clues, so you can get notification for that. Okay, so that is one request from our side, and if it is of your beneficial, please refer to your friends and colleagues to joining. Okay, yeah, and the video will be available. We'll make video available after this live session is over, so you can always come back and refer to this video for your quick reference. Okay, so I am closing this session.